acute respiratory distress syndrome. But before I get started, and even before I do my my obligatory opening remarks, I received an email from my good friend Anil, and he is from Mauritius. And he says, hey, I hope you're fine. Always enjoy our PerfWeb programs. Thank you very much, Anil. He would like some advice. What is the flow you keep in adult VA and VV ECMO, as well as in pediatric VA, VV ECMO? And where do you advise connecting the CRRT in a CardioHelp ECMO machine? Can you please send me a photo or drawing on WhatsApp and his telephone number? Best regards, Anil. So, first of all, Anil, if you're watching today, thank you very much for this great email. Glad to have gotten it. Couple of things just off the top so that we can kind of get that out of the way is we don't do pediatrics. So I can't help you at all with that. With the adults, can absolutely help you. The second part of this, as far as a CardioHelp machine is concerned, we don't use CardioHelp. However, it really doesn't matter what system you use. You can get the CRRT machine connected to it, and there are really good reasons for it. But what's really interesting to me is this program had been planned prior to me getting this email from you, which I thought was very interesting. And the first part of the program today, the Journal Club, is actually about using a CRRT machine, which we use the Baxter Prismaflex machine. It used to be the Gambro Prismaflex machine, and that's the one we're going to be using as our example today. But there are others out there, and in the EU, you guys have different machines than we have here available to us in the United States. But it seems like the Baxter Prismaflex, the Baxter Prismax, and the Next Stage machines are the ones most popular. Braun used to have a machine, B. Braun, but they don't have one here in the United States that I'm aware of at this time. But to do true CRRT, you cannot use a dialysis machine, you doing SLED or any of that kind of stuff. It really is not CRRT, but that's a totally different subject. I don't want to get into that. This is about integrating CRRT into your ECMO circuit, but the first part of the program is about using a CRRT machine and integrating an oxygenator into it. So exact opposite of what your question was, but both of which I was already planning on discussing today. So very interesting, and doesn't surprise me because there's good reasons for it. And I'm going to actually go over the reasons why you want to be able to integrate your CRRT machine into your ECMO on patients who are already on ECMO that then need renal replacement therapy in some form or fashion for whatever the reason may be. Fluid attenuation, acid-base correction, electrolyte correction, metabolite clearance, whatever they go into AKI, ARF, and you need to deal with that. So there's all kinds of reasons that you would want to do it when you have a patient on ECMO versus having to stick the patient. We'll talk about that here in just a second. But anyway, I do have your email. Appreciated it so very much, and we'll move forward with our obligatory housekeeping notes. Contact us, contact@perfusioneducation.com. It works every time the way it's supposed to. Our call-in number, which you're going to see right here, and I'll say it out for those people that may just be listening. It is 832-239-5358. That's 832-239-5358. You can just watch the scroll bar down below that you see here, and it's going to have all of our social media and contact information as well as the call-in number continuously being scrolled down there for your convenience if you want to find it. And it's very important that you please try to like us, follow us, share us, make comments. That's so critically important to make comments on our videos. I cannot thank those of you enough that have done it, but I really have to ask anyone to please make relevant comments to the videos. It would be appreciated by us tremendously. Our MediWeb app is for sale. As you know, it's $2.99. It's highly comprehensive. It covers everything from perfusion to doing your cases on cardiopulmonary bypass, hemodynamic monitoring, ECMO section, conversions, and IV rate and dose calculator for any medication you can possibly think of that you're giving. It's a very convenient app. There's a standalone IV rate dose calculator app, which is 99 cents. You can buy the big app for $2.99, get all of it, or just that smaller app for 99 cents if somebody only needs that part of it. But either way, as far as I'm concerned, tremendous value and tremendous utility. So I highly recommend that. Podcast, you can go to your favorite streaming podcast platform and you can listen to us on your drive into work. You can listen to us, you know, when you're trying to go to sleep at night, for example. If you have insomnia, this will help you fall asleep, I'm sure. But there's a lot of opportunities to listen to our podcasts, and, you know, they spend a lot of time putting them together so that they are functional in that way and are actually quite popular, which I'm really excited about. I'm very happy about that. A lot of what we do everything live. And those of you who don't know, I've said this a few times before, in order to get Category 1 CEU live, you have to watch this program live. I can't record these, pre-record them, polish them up, make them look pretty, and then air them. I can do that, but they will not be approved for ABCP Category 1 live programs, of which you can get an unlimited number of those. You can get 10 maximum SDCE, which is self-directed. Those are already broadcast or already produced, and you watch the video. But in order to get those live, just like you are at a conference watching it live, you would need to watch this program live. Therefore, we have to air it live. And of course, that's fun, challenging, sometimes a little stressful, but very rewarding at the end of the day. I hope our programming is really doing some good in the perfusion community. I wanted to bring up two other things if I can. One is I hope that our colleagues in southwestern Florida and middle Florida and now the east coast of Florida, all of our perfusion colleagues and cardiac surgery colleagues and medicine colleagues and just all of the people there are going to be okay. I know that there is loss of life, you know, and any loss of life is terrible, but hopefully it's minimized as much as possible, and anyone that does still need saving gets saved. But nevertheless, our thoughts and prayers go out to all of those people, and I hope everybody ends up okay. That's the first thing. The second thing is, and I already forgot what it was, so I'm going to have to just move on from there, and we'll, if I remember, I'll circle back to it, I guess. Okay. Yes, so I need to share my screen again. We lost screen sharing. Absolutely, sir. That's what I love about technology. Okay, I'm sharing. It's going in circles. There, I just saw a checkbox. We're good? Yes. Okay. All right, so let's go ahead and jump right into our journal club, and thank you all very much for your patience with my opening remarks. The journal club is, as I said, management of COVID-19 patients, and it's published out of a SIO just recently, this August 23rd, and it's titled Extracorporeal CO2 Removal During Renal Replacement Therapy to Allow Lung Protective Ventilation in Patients with COVID-19 Associated Acute Respiratory Distress Syndrome, or COVID, or basically ARDS. Their abstract is thus: the aim of this retrospective multi-center observational study is to test the feasibility and safety of a combined extracorporeal CO2 removal, or ECCO2R, plus renal replacement therapy, RRT, system to use in ultra-protective ventilatory settings while maintaining an effective support of renal function and values of pH within the physiologic limits in a cohort of coronavirus infectious disease 2019 patients. Among COVID-19 patients admitted to the ICU unit of 9 participating hospitals, 27 patients with acute respiratory distress syndrome and acute kidney injury, AKI, requiring invasive mechanical ventilation undergoing ECCO2R plus RRT treatment were included in the analysis. The treatment allowed to reduce tidal volume from 6 plus or minus 0.6 mLs per kg at baseline to 4.8 plus or minus 0.8, 4.6 plus or minus 1, and 4.3 plus or minus 0.3 milliliters per kilogram. Driving pressure from and also driving pressure, which is listed as delta P, from 19.8 plus or minus 2.5 centimeters of water pressure to 14.8, 14.38, and 10.2 centimeters of water pressure after 24 hours and 48 hours, and at discontinuation of ECCO2R plus RRT. And that's going to be seen in Table 3. Retrospectively, and this was statistically significant, PaCO2 and pH remained stable. Plasma creatinine decreased over the study period from 3.3 to 1.9 and 1.27 milligrams per deciliter after 24 and 48 hours of treatment, respectively, and this was also statistically significant. No patient-related events associated with the extracorporeal system were reported. These data show that in patients with COVID-19 induced ARDS and AKI, ECCO2R plus RRT is effective in allowing ultra-protective ventilatory settings while maintaining an effective support of renal function and values of pH within physiologic limits. So there's their summary, their abstract. And basically what they're saying is that if you have a patient with COVID-19 and you want to do lung protective ventilation, and that patient, and actually really you want to do, let's say, ultra lung protective ventilation, and really lower the tidal volume down in the 4 milliliter per kilogram range, you're going to need something to blow off that CO2, because if you don't, the patient is going to become very hypercarbic. You're going to have a very acidotic pH, and we all know that the result of that is problematic. So, you know, what can they do in order to correct this problem? Although most of the patients affected by severe ARDS syndrome from coronavirus or SARS-CoV-2 infection, they have a favorable outcome. Pneumonia and severe hypoxemia can lead to acute respiratory distress, ARDS, which is associated with a high mortality rate. So let me go over that one more time. Although most of the patients affected by severe acute respiratory syndrome, coronavirus 2, also known as SARS-CoV-2 infection, have a favorable outcome, pneumonia and severe hypoxemia can lead to ARDS, which is associated with a higher mortality rate. So basically what they're saying is most people that get this are going to do fine. Those that develop pneumonia and severe hypoxemia are not going to do fine. We know that. Lung protective strategies are the mainstay of mechanical ventilation in patients with ARDS, as the use of tidal volumes down around 6 mLs per kilogram of predicted body weight, and end inspiratory plateau pressures of less than 30 centimeters of water pressure improves survival. However, several studies showed that conventional protective ventilatory settings may not systemically protect the lungs from ventilator-induced lung injury, also known as VILI, V-I-L-I. Ultra-protective strategies vis-a-vis a tidal volume as low as 4 milliliters per kilogram and a plateau pressure of less than 25 centimeters of water, integrated by extracorporeal CO2 removal to minimize the risk of severe respiratory acidosis caused by the reduction in minute ventilation, have therefore been proposed to further minimize the risk of VILI. It has been recently proposed that ECCO2R could be performed adapting conventional renal replacement platforms like the Prismaflex that I'm going to show you to incorporate a membrane lung to allow CO2 elimination, allowing extracorporeal support of both respiratory and renal function. This may be of interest for patients with COVID-19 ARDS because, one, acute kidney injury, AKI, is common among critically ill COVID-19 patients, with about 20% of the patients requiring RRT. Two, mechanical ventilation is an independent risk factor for mortality in patients with AKI. I didn't know that. And three, high dead space and low compliance of the respiratory system, often occurring in patients with COVID-19 associated ARDS, may limit the efficacy of conventional protective ventilatory settings. All of that made a lot of sense. One thing in there, I did not know that that mechanical ventilation is an independent risk factor for development of AKI. I didn't know that. The current study set out to examine whether in patients with COVID-19 induced ARDS and AKI, the use of ECCO2R during RRT allows the use of ultra-protective ventilatory settings while maintaining, one, an effective support of renal function, and two, values of pH within physiologic limits, because of course you blow off the CO2 and your pH is going to come back up and you're going to be a lot happier. Generally, you don't want to see the pH much below 7.29 really, if you can avoid it. You can allow some hypercarbia, permissive hypercarbia, and I've seen it, you know, obviously with compensatory with compensated respiratory acidosis. I've seen bicarb levels up in the 45, 50 range with a pH of 7.3 and a PCO2 of 71. And I've heard some people, some of the pulmonologists that I was talking to saying if this patient survives, that's probably where they're going to have to live. So in those particular patients, any loss in renal function, because that's where that compensation is coming from, as you could well imagine, is going to be a very, very, very big problem. And I do want to take a short break and tell you about our program that we're going to be doing on the 22nd of October, where I am going to have Dr. Kultulni from Thailand, who is up currently at Brown University in Maine, and Rhode Island, I'm sorry. And we're going to have Dr. Navar, physiologist from Tulane. Both of these people are renal expert. They're physiologists, but they are renal expert. And they are going to be talking about the kidney, how it actually functions, what its autoregulation is, how does cardiopulmonary bypass affect it, what about loss of pulsatile flow, Does pseudo pulsatility from the heart-lung machine really provide sufficient pulsatility? What about volume status? What about third spacing? A lot of stuff. So all of these programs are intended for you to watch them in sequence because each will dovetail into the other. So you're not going to want to miss the special program on the 22nd. Anyway, let's go ahead back to the slides. Methods, getting back to our journal club. The study was conducted retrospectively, reviewing electronic records of patients enrolled in clinical database collected in the period of January of 2020 through June of 2021. Now, that would be that this comes from Italy, and so during that time frame, Italy had the height of their COVID, their coronavirus pandemic, how it affected, when it was affecting them. Institutional review boards of 9 Italian hospitals. I won't list them. They're in the article. You can see them there. Approved the study protocol. Consent was obtained according to institutional indications. Among patients admitted to the ICU of participating hospitals, patients were enrolled if they met the following inclusion criteria: a worsening respiratory symptoms caused by COVID-19, mild to moderate ARDS requiring invasive mechanical ventilation, driving pressure, such as the difference between end inspiratory and plateau pressures minus positive amount of PEEP, positive end expiratory pressure, of greater than 15 centimeters of water pressure, despite the use of conventional protective ventilatory settings. AKI requiring continuous veno-venous hemofiltration, CVVH, and we're going to talk a little bit about that later, about CVVH versus CVVHD. Two totally different therapeutic modalities. CVVH you want to do, CVVHD is not what you want to do, but we can get into that. Exclusive criteria were duration of mechanical ventilation of less than 48 hours. This is exclusion criteria, mind you. Patient eligible for extracorporeal membrane oxygenation, or ECMO, following ELSO criteria. End-stage renal disease requiring dialysis, decompensated heart failure or acute coronary syndrome, severe chronic obstructive pulmonary disease, acute brain injury, severe liver insufficiency, or fulminant hepatic failure. Heparin-induced thrombocytopenia, contraindication for systemic anticoagulation, platelets of less than 50 per liter, catheter access to femoral vein or jugular vein impossible, pneumothorax, incomplete records for the variables of interest, and anyone that was a do not intubate, do not resuscitate if they had that on order. So this is a very restricted study on very, very specific patients to evaluate feasibility. All patients matching inclusion and exclusion criteria received ECCO2R during RRT with the Omni blood purification system made by B. Braun from Germany, available for clinical use in all sites. This is in Italy. It's not available here in the United States. This blood purification system is equipped with a polymethylpentene membrane lung, which comes from Italy, Eurosets, connected to a fresh gas flow source with 100% oxygen at a suggested rate of 8 liters per minute. That's the sweep. And inserted before the hemofilter. So you have your access, and I'll show you the diagram. Access into the oxygenator, out of the oxygenator, into the CRRT machine or hemofilter. The hemofilter was polysulfone at 1.6 square meters. Vascular access was a right IJ or femoral vein or subclavian veins, and was performed using a 14 French double lumen catheter, which is similar to, this is an Omnicath by B. Braun. Basically, it's a Maherker catheter, a Quinton catheter, any double lumen temporary dialysis catheter is what they are saying, 14 French inside. in size, which is a little larger. We usually use 11 French, but 14 French is a pretty good size catheter. Still not that big, not compared to a 31 French Avalon, right? And it was inserted percutaneously. Anticoagulation was ensured by continuous infusion of heparin to maintain values of activated APTT, a ratio of 1.5 to 2.0 of baseline. And here I'm going to show you the circuit more expanded here. And what you see is now in the dialysis world, for those of my perfusion colleagues, everything is backwards. So you have to remember that. Red is your access. Blue is your return. And people ask all the time, that's crazy and doesn't make any sense. But it does make sense for them. And I'll tell you why. When you take blood out of a vein or an artery, doesn't make any difference, and you run it through a hemoconcentrator, and then you hemoconcentrate that blood, the hemoglobin goes up. When the hemoglobin goes up with no change in oxygen content, the color darkens. Hemoconcentrated blood is always darker than it is pre-hemoconcentrated. Therefore, red is excess, blue is return. But for us, that's backwards. Understand. So here comes your red line coming out, coming up. Here is your peristaltic or roller pump, whichever you prefer. It's going up here into a bubble trap of some sort with pressure monitoring is what they're showing here and here. Goes into your oxygenator or your gas exchange module, if you will, because you're not looking for much in the way of oxygenation here. You're really looking for CO2 removal, and it's labeled ECCO2R, so your CO2 removal device. It comes out now with the CO2 removed into your CRRT hemofilter, and then it's going to come down through another bubble trap and back into your patient. Here you have your purple, which is replacement, where you're ultrafiltrating the yellow, replacing it with purple, and your green is your dialysate, so you can run your dialysate fluid counter current if you choose to do dialysis with it as well. Or you can shift these things and have purple going post-filter, purple going post-filter and green going pre-filter, and it depends a lot on the device that you're using at the end of the day. Yellow is ultrafiltrate, so that you know what that is. Okay, that takes care of that diagram. And remember, the sweep gas was they recommended 8 liters per minute. Okay, PTT, if you remember, APTT was 1.5 to 2.0 of baseline. So remember that, okay? Patients were treated with an ultra-protective vent strategy simultaneously with CVVH. This strategy was applied with the following protocol. RRT, renal replacement therapy, was commenced at a flow rate of 300 mLs per minute, and a sweep gas was set at 0 liters per minute. Now, that's how they started it. Again, when you look at a flow rate of 300 mLs per minute, when you compare that to ECMO at 4 liters, that's very, very low. But it's also, in comparison to having an 11 French Maherker catheter, pretty good flow for a CRRT machine. 200, and a lot of times you're outside of you have really high pressures, access or return pressures, depending on where the catheter is, up against the wall, whatever it may be. So having 300 mLs per minute is not too terribly bad, but they started off with no flow at all on the ECCO2R CO2 removing device, okay? Then the tidal volume was reduced to 4 milliliters per kilogram of the predicted body weight in 3 steps, from 6 to 5, from 5 to 4.5, and then from 4.5 to 4 milliliters per kilogram PBW. Again, predicted body weight. Once the lowest value of tidal volume was reached, sweep gas was switched on to 10 liters per minute to obtain PaCO2 values similar to baseline plus or minus 20%. To optimize oxygenation, PEEP and FiO2 were titrated to maintain an SpO2, or a pulse ox, of equal to or greater than 92%. Patients received neuromuscular blocking agents when it was difficult to provide adaptation to controlled ventilation with deep sedation as directed by the attending physicians. So, as I said earlier, 300 cc's a minute is not very much. These patients have to not be having as much of an oxygenation problem as they are having a CO2 clearance problem. And it looks to me like they're willing to, although 92 is pretty decent, but they're willing to tolerate a much lower arterial saturation. And I've seen as low as 80, 81, 82, and that people say that is acceptable. I don't believe it is. I think that we have come to accept values that are far too low because I believe it's DO2. You look at DO2 is so critically important in these cases. But nevertheless, you know, you look at the data from years and years ago with Schumacher and Rivers and all these people that did all the work on DO2 and survival. You know, we're kind of going the opposite direction because you get a PaO2 of or a saturation of down around 81%, 82%. Yeah, you probably keep the brain alive, but I'm not sure it's good for the other organs, and I think you start having other issues develop over time when you do that. I think you need more ECMO flow. I think if you need to have extra cannulas, but we're very averse to doing that. You know, it's like it's not in our comfort zone to do it, and there's risks. There's obviously risks of that too. There's risks this way, there's risk that way, and you have to weigh those risks and make the decision as to which risk you think is greater or lesser, as the case may be, and go that direction. Data were analyzed for feasibility to achieve and maintain a tidal volume of 4 mLs per kilo of ideal body weight and a plateau pressure of less than 25 or less centimeters of water, with a PaCO2 not increasing more than 20% from baseline and a value of arterial pH greater than 7.3, while providing effective RRT and safety, occurrence of severe adverse events and of mechanical clinical ECCO2R related adverse events as previously described. Static compliance of the respiratory system, described as CRS, was calculated as tidal volume divided by plateau pressure minus total PEEP. Driving pressure was calculated by tidal volume divided by compliance of the respiratory system. Oxygenation was quantified as the ratio of partial pressure of arterial oxygen to fractional concentration of oxygen-inspired air. In other words, a PF ratio. Ventilatory ratio, described as VR, was calculated as minute ventilation times the PaCO2 divided by the predicted minute ventilation times predicted PaCO2 and used as a surrogate of dead space. So they did a lot of fancy mathematical calculations, all of which make sense. None of which I think any of us need to remember off the top of our heads, but I would kind of stick this article in your bag, because there's a lot of really neat anecdotes to it that pearls that you could use in different circumstances. Clinical variables were collected before the start of ECCO2R plus RRT. T0 after 24 hours identified as T1, and 48 hours identified as T2, and a discontinuation of ECCO2R plus RRT, which is identified as T3. So you have T0 before it starts, T1, 24 hours, T2, 48 hours, T3 at discontinuation. Creatinine concentrations at ICU admission were also calculated on the same T0 to T3 time period, and length of hospital stay and mortality at 28 days were recorded. Data, unless otherwise stated, are presented as mean with standard deviation for continuous variables and as frequencies, proportions, and percentages of categorical variables. Repeated measures for continuous variables were compared with the Kruskal-Wallis test. Now, I don't really know what that is, but I'm sure it's some kind of statistical analysis. Each row represents matched observations. Categorical variables were compared by these various things. I think this is, we can move on from this one. Results. 27 patients were treated with the ECCO2R plus RRT. It was initiated 11 plus or minus 9 days after ICU admission and discontinued after 4.3 plus or minus 2.2 days for death in 14 patients and for normalization of renal function in the remaining 13 patients. So 50-50 or 49-51, with it 49 being survivors, 51 being non-survivors. Clinical variables before initiating the ECCO2R plus RRT treatment are reported in Table 1, and we'll explore that. All patients were ventilated in volume-controlled mode and received a propofol and opiate-based analog sedation regime. Creatinine amounted to 3.3 plus or minus 1.27 milligrams per deciliter, and all patients had a KDIGO, kidney disease improving global outcome, class of 3, which is high. Modes of RRT implemented were continuous veno-venous hemodiafiltration in 15 patients, which is the most intensive therapy you can do with a CRRT machine. So that's referred to as CVVHDF, continuous veno-venous hemodiafiltration. And there's continuous veno-venous hemodialysis, which is CVVHD, which I don't believe in 6 patients, and continuous veno-venous hemofiltration, CVVH, which is my preferred go-to therapeutic modality. The PF ratio, compliance, driving pressure, and VR amounted to 108. And let's just go to the diagram. There we go. This will tell us everything we need to know. Here's the basic patient demographics. You can see that there. And you can see mortality at 28 days was 63%, quite high. Of course, if you recall, now these patients were not technically on ECMO. So keep that in mind, please. This is a totally different hybrid system, which I showed you earlier. And here you see their settings, tidal volume 454, their tidal volume, their to their predicted body weight, 6 mLs per kilogram, their respiratory rate, minute ventilation, PEEP, plateau pressures, pH, CO2, bicarb levels, you can see they're a little high, so you're going to have compensation there. Base was plus 5.7 expected. PF ratio 108, plus or minus 29, which is pretty doggone good. Not good, it's not normal by any stretch, but we had a lot worse than that. We were putting on patients on ECMO with PF ratios of 60 by the time we were getting them. Their compliance, you can see there, is 23.2. Their driving pressures, 19.8, and their VR, their ventilatory ratio was 2.9, plus or minus 1.1. There's that data. Blood flow and sweep gas set on the platform ranged between 186 and 393 milliliters per minute and 9 to 11 liters per minute, respectively, on the sweep, right? Infusion of heparin maintained the APTT ratio of 1.12, 1.64, 2.02, and 2.08 at T0, T1, T2, T3, respectively. Renal dose amounted to 32, plus or minus 3.3, 32, 31, and 31 milliliters per kilogram per hour at T0, T1, T2, T3, respectively. Time course of ventilatory variables is reported in Figure 2. Initiation of treatment allowed to reduce tidal volume from 6 mLs per kilogram to 4.8 and 4.6, then 4.3. And the plateau pressures dropped from 28 all the way down to 21, and the driving pressure from 19 all the way down to 10. And this is on T1, T2, T3 time frames, respectively. Despite a approximately 30% reduction in minute ventilation and about 10% reduction in respiratory rate, PCO2 remained stable, whereas pH slightly but significantly increased from 7.3 ultimately to 7.4 from T0 to T3, which was statistically significant. No change in systemic oxygenation was observed. Well, I would not consider that slight. I would consider, I would consider that significant. I would say, I mean, it's statistically significant, but to me, that's clinically significant too. So I found that sentence a little awkward. I don't know why they said it that way, but for me, that's a lot. And we can make a blow up of this. There you go. And so in the top here, you see tidal volume, you see respiratory rate, you see minute ventilation, you see plateau pressure, PEEP, and driving pressure, and you can see that all of those improved significantly over the course of time in that top section. And down at the bottom, you have PCO2, pH, and PF ratio, and you can once again see those all improved over time with the use of baseline 24 hours, 48 hours. That's T0 to T3, which is end. And if you look down here, the PCO2, you can see that it is decreasing. Here you see the pH increasing. Here you see the PF ratio improving. So you saw the same thing up in this section here. Everything did get better. Creatinine at ICU admission amounted to 1.93, plus or minus 0.47, and significantly increased to 3.3, plus or minus 1.27, leading to initiation of RRT that resulted in a significant decrease in plasma creatinine over the study period, 1.9, 1.7 at 24 and 48 hours of treatment. So that's a big drop. At the end of the study treatment, plasma creatinine amounted to 1.0 plus or minus 0.7, which again, that's very good. So you have very good clearance with this technique. But I think that the CRRT portion of it, the clearance of metabolites portion of it, is completely unaffected by the CO2 removal portion of it. That's going to happen no matter what, especially with those, if you have really good flows on your CRRT machine. So that's a totally different phenomenon. Now, whether the kidneys recovery was improved because of the increase in pH, the removal of the PCO2, which resulted in the increase in pH, is a totally different question, and really what I think we're trying to understand here. No patient-related events directly attributable to the combined use of the ECCO2R system and the CRRT were reported, except for 4 episodes of premature circuit clotting, which required circuit replacement. The small cohort of patients undergoing ECCO2R plus RRT did not report any major bleeding episode, hemolysis, or infections related to the system. So in discussion, results of this retrospective observational multicenter study show that in patients with COVID-19 induced ARDS and AKI, ECCO2R plus RRT is effective in allowing ultraprotective ventilatory settings while maintaining, 1, an effective support of renal function, and 2, values of pH within physiologic limits. Mechanical ventilation may cause a form of injury that is clinically and morphologically indistinguishable from ARDS, which is very true. You know, you can develop ventilatory associated ARDS, and you don't know if that's what caused this problem, or is it this virus that's causing this problem, or the virus is causing the problem, but our mechanical ventilation is making it worse because their lungs are stiff and we're having to push harder and harder. All of these things are interrelated. Totally agree with that. A seminal randomized clinical trial demonstrated that limiting tidal volume to 6 milliliters per kilogram and plateau pressures of 30 or less improves survival. Well, I think we all agree with that. And if you don't have it like that, I know it improves survival because I can't tell you how many pneumos I saw get blown because we were trying to push in 120 cc's into the patient's lungs with their peak pressures running 35, 38, 40, 42, 46. And then the next thing you know, you look at your VTE and it is less than your VTI, in other words, your tidal volume expiration versus your tidal volume inspiration. They're no longer equal, with the VTE being lower. The air's going somewhere, and you just watch it over time. Patient becomes hemodynamically unstable, get a chest x-ray, take a look, big giant tension pneumothorax, chest tube goes in. I saw that happen so many times that I don't put chest tubes in, but I saw enough get put in. I think I could do it now. Let me see where I'm at here. Amato and co-workers showed that these protective ventilatory settings were effective if associated with a decrease in driving pressure, that's a plateau minus PEEP, and that protective ventilatory settings are associated to a lower risk of death only for values of driving pressure less than 15 centimeters of water pressure. So you really have to get that driving pressure below 15 centimeters of water pressure for there to be a survival benefit. Several studies demonstrated that conventional protective ventilatory settings may not be always protective because some patients may still present morphological or physiologic evidence of villi with tidal volumes of 6 milliliters per kilogram of predicted body weight and plateau pressures lower than 30. Reduction of tidal volume to 3 to 4 milliliters per kilogram and plateau pressures of 25 or less has been proposed to further minimize the risk of ventilatory-induced lung injury. But this entails a significant risk of severe respiratory acidosis. ECCO2R can minimize this risk by clearing CO2, enabling strategies that are more protective and might improve outcomes by 1, using tidal volume as low as 3 to 4 milliliters per kilogram, and further decreasing plateau pressure below 30 centimeters of water pressure, often termed unprotective. 2, decreasing respiratory rates. 3, minimize driving pressures and mechanical power. A recent multi-center randomized clinical trial conducted by McNamee and coworkers has stopped early for futility because tidal volume reduction facilitated by ECCO2R did not reduce mortality. It should be noted that conventional protective ventilatory settings failed to maintain values of driving pressure less than 15 centimeters of water pressure in about 50% of the patients included in the McNamee trial, whereas all patients included in the current study had values of less than 15 centimeters of water pressure for their driving pressure. So, important point there. Several single-center studies reported the possible allocation of a membrane lung within a conventional RRT circuit to allow simultaneously removal of fluids and metabolites with the hemofilter and CO2 removal with the membrane lung. Forster and co-workers modified a commercially available RRT device, which is the BM11-14 from Edwards. I don't know what that one is, with a standard setup and adjustment for continuous veno-veno hemofiltration, that's CVVH, adding downstream to the high-flux polysulfone capillary hemofilter, a small standard hollow fiber gas exchanger. So they did it after hemofiltration, not proximal, not first, but second, okay? They found that in 10 ventilated critically ill patients with ARDS and AKI undergoing RRT and respiratory replacement therapy, this simple device was feasible and safe and led to a significant CO2 removal and rapid correction of arterial pH with a positive impact on hemodynamic stability. Concomitant RRT was in no way compromised, and alarm functions of the RRT system ensured safe control of the gas exchange device. Similarly, Alardet, Servant, and co-workers modified a commercially available RRT device, Prismaflex, which is the one we're going to use today, set in continuous CVVH mode, adding a polymethylpentene heparin-coated hollow fiber membrane oxygenator, a MEDOS, either upstream and downstream of the hemofilter, so either or. The study enrolled 11 patients and confirmed that combined RRT with ECCO2R was safe and allowed sustained blood purification together with enhanced lung protection ventilation during the early phase of ARDS and AKI. Blood flow through the membrane lung and CO2 removal rates were significantly higher when the membrane oxygenator was placed upstream than when the membrane oxygenator was placed downstream of the hemofilter. So upstream meaning it was proximal, downstream meaning it was distal to the hemofilter. I'm not 100% sure that's what they're saying, but that is how I am interpreting it. Both studies did not report adverse events. Consistently with these data, Finelli and coworkers, using a propensity score analysis, compared patients with ARDS and AKI treated with conventional protective ventilation and RRT with patients treated with ECCO2R plus RRT. Recovery of renal function was more pronounced, and concentrations of inflammatory and apoptotic mediators were lower when ultraprotective ventilation was allowed by ECCO2R plus RRT. Moreover, a multi-center pilot study from Schmidt and coworkers reported the use of conventional RRT circuit equipped with a membrane lung to allow CO2 removal without providing RRT. A polymethylpentene PMP hollow fiber gas exchange membrane up with a surface area of 0.32, so that would be a meter squared, so that would be a pediatric, was added to a conventional RRT platform, again the Gambro Prismaflex or the Gambro Baxter, to allow low flow, 421 mLs per minute, plus or minus 40, and a sweep gas of 10. Standalone CO2 removal treatments. In 20 patients with mild or moderate ARDS, the study showed how this approach allowed to safely reach a tidal volume from 6 all the way down to 3.98 and plateau pressures from 26 all the way down to 22, driving pressures from 13 all the way down to 7.9. However, this occurred with about a 20% increase in PCO2 from 43 to 53. But 53, if you're corrected, if you have a compensated respiratory acidosis, is okay. The relatively large number of patients included in the study, which is 27, and the multi-center design being 9 centers in Italy, represent the major strength of this study. Now, I tend to disagree with that. The relatively large number of patients, an N of 27 from 9 different centers, no, I don't think that's really a major strength of the study. I think it has strong anecdotal data, which I would try. I think it makes sense and can be done safely. I think very well done, very well done in terms of their creativity for this issue, for doing this. But no, I do not see this as a very large study. Our data confirm that the combined use of ECCO2R and RRT allows to safely reach and maintain a low tidal volume and low peak plateau and reduce driving pressure while maintaining constant values of PCO2 from about 70 to 60 and pH from 7.3 to 7.4. They mention here that there was only the 4 episodes of premature circuit clotting, which does not surprise me at all. With those low flows, you're going to have really good anticoagulation, especially if you're using an adult oxygenator. Pediatric oxygenator makes a lot more sense, but the surface area is enormous in comparison. And now you could potentially, if you use a pediatric oxygenator, regionally anticoagulate using ACDA and citrate protocol and running calcium into the patient distal to the circuit or into a separate central line. You could do that, and I think it would work a whole lot better, but that's a different topic for a different day. This profound alteration of respiratory function may explain the value of PCO2 observed in study inclusion and is higher than the PCO2 values observed in some of the previous studies. Thirdly, our sample may have intrinsic heterogeneity since it is a retrospective analysis. Fourth, mortality in these patients was quite high. However, this cohort of critically ill COVID-19 patients was burdened with a particularly poor prognosis and met the inclusion criteria in a late phase of the disease. Also not proven, ECCO2R could be beneficial to reduce villi in the early phases of ARDS and has been suggested as a tool to maintain a protective level of mechanical ventilation. A combined technique should be indicated in case of severe acute renal failure. Therefore, the right timing of a combined treatment should be clarified, taking into account the possible role on metabolic and fluid balance in promoting faster compensation of acidosis. Further studies are needed to compare ECCO2R plus RRT versus ECCO2R standalone. In conclusion, our study shows that combination of ECCO2R and RRT in patients mechanically ventilated for COVID-19 induced ARDS with AKI and in whom conventional ventilatory settings failed to maintain effective protection from ventilatory induced lung injury was able to ensure ultraprotective ventilatory settings while maintaining constant values of PaCO2 and pH and providing effective RRT. Further studies are needed to assess overall benefits of this approach. And that is our journal club for September, what is today? September 30th? September 30th, 2022. All day, every day. And we're going to get some things together. Can you show a wide shot? Do we have any wide shot we can show them of what we have set up here for them? I want you to see this. We're going to go to camera 1 and take a look at this, okay? There's our ECMO simulator off there to the bottom left of the screen. You see our ECMO pump maybe down a little bit on that. Yeah, there. You can't. Yeah. Okay. Well, it's down there. You can see the centrifugal part of it. I don't know if you can see the oxygenator. You might be able to. Yeah, there you go. That's beautiful. And there's our Baxter Gambro Prismaflex machine. So we've got everything set up. We're going to connect it to the ECMO circuit. So again, ours is a different thing. Patient's already on ECMO, needs RRT. Are we going to stick a catheter in the patient, or are we going to integrate it into the ECMO machine? But if you stick the patient, there's risks. But if you put it in the ECMO machine, there are risks. Again, you have to look at the risks and weigh the risks. Also, I needed to make mention that whatever I am going to show you is off-label. So just to make sure that I've complied with anything regarding my obligations, this is all off-label, but we do it all the time. Okay, very good. We take a 5-minute break, come back, and we will get this whole party going. Okay, and welcome back everyone to the program. So what you see here is the Gambro Prismaflex machine. It's been around in service for a lot of years, and it is certainly one of my favorites. It's an excellent technology. I already have it set up. It's passed its prime test. All I have to do now is hook it up into the ECMO circuit. So just to help with time and stuff like that. So I'm going to see if I can sneak through here. And here's our ECMO circuit, our pump here. So can you change to camera 6, please? Yeah. So camera 6, what you should see here is, so this is our access line here. Okay, this is going to be negative pressure, right? This is our return line here. This will be positive pressure, and here's the top of the oxygenator, which is also positive pressure. And what you see is I have created a bridge. You have a line coming out of the top of the oxygenator going right back to the venous line. So positive pressure driving to negative pressure, and I have 2 stopcocks in place, one which will take our access, one which will take our return and hook it up to the CRRT machine. And I'm going to do all of this from the green screen and with everything on the board, the monitor, so that you can see it. So I'm going to go ahead and, if you'd like, go ahead and hook up, that camera, and I'm going to go ahead and connect this. So what normally would happen is, after it's all primed like you see here, you would take the, if you remember, red is your access. Okay. So I've clamped my 2 clamps. I'm going to disconnect it from the priming bag. Here's the line here. So go to camera 6, and I'm going to put it right here. Okay. All right, that's connected. And after connecting it, what I'm going to do is turn the stopcock so that it is all the way around. Okay, there we go. That's that. And I'm going to leave this clamped the way it is. I'm going to take my blue, which is, again, my return. So you probably want to be on the, that camera there. I can come over here. So I've got my blue, and I'm going to disconnect it. And I'm going to go ahead and take my effluent yellow, and I'm going to put it back on the effluent bag, make sure that it's open, and I'm going to take my blue return, and I'm going to connect it to my bridge, distal to my access, and I'm also going to turn that 180 degrees. Now we're going to make a lot of different changes on this over the course of while we do the actual run to show you what different things can happen. Now, Anil, go to camera 4. Anil, if you want to do this with a cardio help, again, it's very off-label, but it would require that you cut a stopcock, you cut a connector, 3/8, 3/4 connector, into your access line, which will be the negative side, and you should have, I believe, on the top of the cardio help, a purge line that comes off. You're going to want to be able to create that loop. If that's not going to work, then what you do is you're going to have to go into the line distal the cardio help, the oxygenator, and put a second 3/8, 3/8 lower lock connector with lower lock there. something that is very important, and I don't know if you're going to be able to show this or not. I think you can. Go to camera 6. I want to show this real quick. That's a good spot. Uh-oh. Sorry about that. You'll notice that all of these connectors have pigtails. I never put a stopcock directly on a connector, ever. I always add a pigtail because a stopcock on there can break off and you can't fix it. It's not fixable. You have to clamp it. You're off ECMO. If you're 100% ECMO dependent, you're in a lot of trouble, and you just have to clamp, cut, and replace that connector. So I always use pigtails on everything. And here's another one here. Pigtail. I never put a lower stopcock directly on a connector. And that's just a safety thing that I think is of tremendous benefit. So my little pearl of wisdom for anybody out there that may do it differently. Okay, so we'll come back to here. Now that I have it hooked up, I have everything turned on, I'm going to go ahead and initiate, and I'll open this up. So now everything is open. And let's go to the multi-screen if we can. Yeah, so just go ahead and leave it there. So at this, something is wrong. So hold on, guys. It appears that this Mevo camera on the ECMO is frozen because I have it at 0. Yeah. Sorry about that. Okay, so go back to camera 4 while he's doing that, and I'll talk to you guys. Okay, good. So I'm still have this in prime test. I haven't told that I connected it yet or anything like that. Let's just get this technical problem solved first, and then we'll go back to that, and I'll start over there. Now, this is not a course or a class in how to manage a CRRT machine. I am assuming that everyone knows how to do this. My only interest today is teaching you how to integrate it safely into an existing ECMO circuit, because what you don't want to do, especially on a patient that may be already anticoagulated, on a patient who might already have a coagulopathy, have to stick the patient and then possibly cause a bleeding problem. So that's what you're trying to avoid here. And in addition to that, there is no way you can compare the amount of flow you can get for your renal replacement device from directly out of the ECMO that you can possibly get using a Quinton or Maherker catheter, or even a 14 French. This is almost unlimited at the end of the day. Okay, let's go back to that multi-pack. And I think we're unfrozen. That's perfect. Okay, so I'm going to go ahead over here now and start this. So we're going to hit continue. I know that I know all of this. I'm going to go ahead and increase the blood flow to, let's say, 250. We're going to start it out there. I'm not going to start any of the other treatments. I'm just going to get the blood running at this point. This will be a continuous rate on the syringe for the region, the heparin anticoagulation. Continue. I know that I've done all this. I'll hit that, and I'm just going to go ahead and get it started. Now, the ECMO is not running, so I'm going to walk over there, if I may. David, I'm going to walk over to the other side. Okay? So, good. Excellent. So, now what you see is an access pressure of, is that a negative? I can't see. Is that, say, negative 36, 34? It's very low. Filter pressure of 14, effluent pressure of 4. I'm frozen. I'm freezing too. Okay, hold on a second, guys. We got to do that too. We always have technical difficulties. I'm smiling though, so that's a good sign. Okay, so while that's going on, so I'm going to go over here. And are Are you going to start camera 7 over again too? Yeah, so the access is negative 36. Okay, so let's go to camera 4. Oh, okay. So with all of that said, we're making adjustments on the fly here, and we get an alarm that says return disconnected. The reason for that is because the value is so low. It expects to see a return higher than 0. But the ECMO, again, is not yet running. So those things are going to happen, but at least it is, in fact, running. So let's see. How we looking?
Let's try it.
We need to try it? Okay. All right. We'll try it. And, yeah, you can just leave that. Okay. All right. How are we looking? That looks really bad.
Take a break maybe for 2 minutes.
Okay. That's a good idea. Okay. So we're going to, let me come back here. We're going to take a break for 2 minutes, is what Magic is asking for, and get our technical difficulties resolved. Please forgive us, and we'll be back in 2 minutes. Hey, check out our sponsor. Oh, we don't have any. That's okay. Just put the screen. Anybody want to sponsor us? Please give us a call. Go to the break screen. Camera 4. Are we streaming? Please stop.
Yeah, we're live.
Okay, are we live? Okay. We have a catastrophic failure. Anil, I am sorry. Anyone else watching right now, I am sorry. But it's not recoverable. And we're going to have to reschedule it. So I'll have to redo this half of the program probably next week, sometime during the day, once we figure out what has gone wrong here. But our entire system is glitching and freezing and for the part on the simulation, and so it will be ineffective. In fact, it's impossible for me to do it. So please forgive us. We will send a notification out to everyone when we will reschedule the second half of this. And again, my most sincere apologies, but such is the life of live. Okay, kind of cut me out. I'm done.